Good afternoon, friends. I'll be talking on approach to constipation, and we have this very familiar picture on the screen of this gentleman in today's time sitting on the pot longer than required with his lota down there, and of course, because he's more busy looking at his SMSs and WhatsApp and reading the newspaper. So this is a typical scene happening all over the country or maybe all over the world. But look at this picture carefully and think what may be the problem in this picture. Because through my talk, I will discuss more about this position or this posture. So how do we approach a case of chronic constipation? First is we take a good history, a good physical examination, basic blood investigations are done, and then usually patients would either have self-medicated them with fiber or they would have seen their family physician for which they would have taken some laxative. And only if there is inadequate response or they are not satisfied or they continue to have a problem, that's when they get referred to us gastroenterologists. So how do we define constipation? For everybody, the definition is different. I'll come to the medical definition later, but let's just look at the picture. Because from the picture, you can show it to an educated person and a non-educated person. And everybody can look at a picture and tell them how their stool is. Because many times I face that in the clinic that you ask the patient, how is your stool? And the husband or the wife or the mother of a grown-up child will answer. I always wonder, how is it that other family members are looking at the stool of the patient? So usually if you show a picture, the patient should be able to tell you well. And the type 4 is usually what is considered like a sausage is considered as normal stool. If you have type 1, 2 or 3, then you have more the constipation type. And if you have soft blobs and fluffy pieces or liquid watery stools, then you have a diarrhea predominant kind of a stool. So this is called the Bristol stool scale chart, and this is commonly used to tell the patient what type of stool they have. When you come to the criteria, by definition, for defining chronic or functional constipation, there is a Rome 4 criteria, which says that at least 2 or more of the following should be present. Patient is straining. He has lumpy or hard stools. He has a sense of incomplete evacuation or a sense of anorectal blockage, or he uses any manual maneuvers to facilitate the passage of the stool. And he has less than 3 bowel motions per week. So if any 2 or more of these symptoms are present, then you can say that your patient suffers from functional constipation. The American Gastroenterology Association defines constipation as normal transit, that is the speed of passage of stool through the colon is normal, a slow transit, where the speed of passage of stool is slow, or a defecatory disorder, that is the transit time is normal, but the patient is not able to evacuate the stool from the rectum outside. It's very important that we must differentiate constipation from irritable bowel syndrome predominant constipation. The difference is that in irritable bowel syndrome patients, they have associated abdominal pain, which is related to defecation, and it is associated with a change in frequency or form of stool. We must rule out any systemic diseases which may be contributing to the constipation. So does the patient have a colon cancer? Is there a stricture? Is there any metabolic condition like diabetes mellitus, hypothyroidism, heavy metal poisoning? Or are there any neurological disorders like Parkinson's or any other cognitive impairment? We must take a detailed history to find out which drugs the patient is taking, because there's a whole long list of drugs. The antiemetics, ondansetron, the painkillers, the opioid analgesics, many antihypertensive drugs like the calcium channel blockers, are antidepressants, antipsychotic, anti-Parkinson's drugs. All of them cause constipation. So a good drug history to find out which drugs the patient may be taking, which may be contributing to the constipation, is important. In who do we do tests? Anybody who has what we call red flag signs. Red flag signs means if you are age more than 50 and new onset constipation, that's a red flag sign. Do you have anemia, especially iron deficiency anemia? Is there 10% weight loss in the last 3 months? Any blood in the stool? Does the symptoms wake you up in the night and want you to go to the toilet? If there is family history of colon cancer or inflammatory bowel disease, or on examination you find an enlarged liver or spleen or ascites or a mass, all these things are red flag signs, and anybody with red flag signs needs investigation and should not be sent away with only a laxative prescription. A per rectal examination to examine whether the rectum is empty, whether there is impacted stool, whether the patient is able to expel your palpating finger to look for defecatory disorders, are all essential and should be part of your regular physical examination. Everyone should not have a colonoscopy unless they have any of the previously mentioned alarm symptoms. Rectal examination, after you look for any blood or any other painful fissure or any other cause which may be contributing to the constipation, you tell the patient to try to push your finger out. In a normal person, the anal sphincter relaxes around the finger and patient is able to expel the finger. But in people with pelvic floor dysfunction, where they cannot relax the sphincter, they paradoxically contract it, and this causes pelvic floor obstruction, which impairs their ability to pass stools. What is the common treatment that we follow or that we advise? There is lifestyle and there is drugs. Most patients will take either a fiber or osmotic laxative, and we have to understand that whether the patient has slow transit constipation or normal transit constipation, long-term use of laxatives is the mainstay of treatment. We ask them for a dietary modification, especially if they are not taking an adequate diet. So if somebody is already taking adequate dietary fiber, then advising extra fiber is of no consequence. If people are not taking adequate water, then you can recommend them to drink more water. And certain fruits like prunes, dried plums, have been tried against psyllium, that is isabgol. And it has been found that these fructose-rich fruits, when taken between 7 to 10 pieces per day, have been found to improve bowel symptoms, and they may be as or even more effective than isabgol. Many high-fiber fruits are present, which are commonly recommended to patients if they are not taking adequate fiber intake. You should find out whether they have a sedentary lifestyle, telling them that 30 to 60 minutes of exercise every day helps in improving stool consistency. Drugs. There's a whole list of drugs, whether you're using fiber, whether you're using osmotic laxatives like lactulose or polyethylene glycol, or stimulant laxatives like picosulfate, bisacodyl, or senna, saline laxatives like milk of magnesia, or intermittent enemas, or other specific drugs like lubiprostone and procalopride, which affect colonic motility or increase secretion into the colon. The last three, linaclotide, plecanatide, and ilobexapac, are currently not available in India, but are licensed for use in the US. So any drug that you are comfortable with, that you can choose to start for the patient. You have to start one. If the patient doesn't respond, increase the dose or reach the maximum dose. If they still don't respond, add another laxative or switch to another laxative. And you need to give a combination of sometimes fiber with osmotic laxatives or osmotic laxatives with stimulant laxatives to achieve the end result to help them with their constipation. I also advise them about the posture, and that's why I was asking you to look at the first slide very well. What was wrong? People are reading the newspaper, spending time on their mobile, and that is distracting them from the aim with which they have gone to the toilet. So studies have shown that if you are squatting, that is our Indian style toilet, then you need less time and you need less pressure, less expulsive effort is required in an Indian style toilet as compared to a commode type toilet. And that is where the importance of the pelvic floor comes. You can see over here that when a person is told to bear down or strain, the anorectal angle increases. On the left side, we have what is at rest. That's the anorectal angle you can see. And when the patient strains, the anorectal angle should open. But this is in a normal person. There are some people who, when they strain, they do not open their anorectal angle, but they actually reduce it, and this worsens their constipation. So the correct posture on a Western commode, which because now more and more people are using this type of commode, is that your knee should be at a higher level than your hip joint. So if your commode is high and your height is short, you may need a small stool of 4 to 6 inches to help raise this. You must keep your back straight, your hands on your legs, and when you strain or push, your stomach should come out and not go in. That's how you strain correctly while passing stool. That's the correct posture. So when we have a patient who has not responded to the therapeutic trial of laxatives, and after lifestyle changes, we still have to investigate further. Then we do something called as an anorectal manometry with a balloon expulsion test. What is it now? Anorectal manometry is a pressure study of the rectum and the anal canal along with a balloon which the patient is told to push out as if attempting to pass stool. If the anal manometry is normal, then we say the patient does not have a defecatory disorder, and we must do a transit time to see whether the patient has slow transit constipation or not. But if the anal manometry is abnormal, that is, he is not able to relax his external sphincter while he's pushing down, then he needs further therapy. This is how a manometry reading looks like. This is the catheter with a balloon, and this balloon deflated is kept inside the rectum, and pressures are measured, and patient is told to expel a 50 cc balloon. In a patient with constipation who is not responding to laxatives, the common cause is that they are not able to relax the anal sphincter. This horizontal pink thing which is going is your anal sphincter, and vertically what is coming from the top is the rectal propulsion forces. When the patient is trying to push down here, you can see that it is becoming black. So what does black mean? Look here on the right side. If pink, which is 50, is becoming 100, that means the pressures are rising. That is paradoxical contraction of the anal sphincter. So in a normal person, when a person bears down, the anal sphincter should relax and open. But in some of them, it closes, and this is what causes constipation. And they have a sense of incomplete evacuation. Sometimes they digitally use their fingers to remove the hard stool. Sometimes they use the water jet to give themselves an enema. And this is called pelvic floor dysfunction or dyssynergic dysfunction. So what is the treatment for this? It is called biofeedback. Biofeedback is where we train the patient on the machine by visual, auditory, and verbal means. A simple task like how to relax their anal sphincter, and they are taught how to evacuate the rectum. So some people will laugh, what is there in doing this? I am doing this since I am born. But please understand that passing stool is a learned reflex. When you were born, you didn't know how to evacuate. You did potty all the time. and when you were about 2 years old, your parents toilet trained you. So anything that is learned or taught can be forgotten, or a wrong habit can be developed, because of which you are not relaxing your anal sphincter. So we teach them diaphragmatic breathing exercises. We teach them exercises how to relax the anal sphincter, how to do a recto-anal coordination. We do stimulation of defecation with a balloon. If they have what is called a megarectum, that is, they store a lot of stool and they don't get a sensation easily, we do a sensory training. And all this is called biofeedback. Patients need 8 to 10 sessions of about 20 minutes each once a week. And then they practice these exercises at home so that they can achieve satisfactory defecation. There are multiple studies and shows that biofeedback training for constipation is an effective modality of therapy. As I said earlier, if the anal manometry is normal, then you need to see, does the patient have a slow transit or a delayed transit? Here, multiple capsules are given and X-rays are taken at day 1, day 2, and at day 5 to see the amount of residual markers remaining in the colon. If you have excess of 20% of markers, these radiopaque markers remaining in the colon, then you can say that the patient has a slow transit. If the markers are distributed along the length of the colon, then that is a slow transit of the large bowel. If they remain in the pelvis, then you say that it's probably secondary to the defecatory disorder, because of which they cannot expel the colonic markers. So in a person with slow transit constipation, we usually give laxatives. We give a combination of polyethylene glycol along with a stimulant laxative like bisacodyl. And if it improves, great. But if it does not improve, then we use the newer pharmacological agents which improve colonic motility like prucalopride. But say it does not improve, say everything you have done to improve colonic motility, but you're not getting the desired result, then you must think, is there a problem at the upper end? Is it that the stomach and the upper part of the GI tract, are they working properly? And if required, you may do what is called as gastric emptying study. Gastric emptying study is where you give a solid meal of roti, sabji, and dal, in which a sulfur colloid technetium is mixed, and then you look over the next 4 hours how the patient's stomach empties, at what speed, and how much residue is there. If more than 10% of the tracer is present at 4 hours, then you say that the stomach muscle is also not working, and that may be contributing to the delayed emptying and may be contributing towards the constipation. So if the gastric emptying is slow, then you know that there is a problem at the upper end of the gastrointestinal tract, and then that needs to be treated. But if the gastric emptying is normal, then you have to decide that a person with slow transit, does he need a subtotal colectomy because of extremely slow transit? If the patient has a defecatory disorder, that is, he's not able to evacuate stools and the anal sphincter is not relaxing, as I said, we do pelvic floor training and repeat the tests. If the tests are still abnormal, then you want to do an MRI defecogram to see whether is there any anatomical obstruction to the passage of stool. And if there is a large rectocele which is retaining the stool products, then maybe surgery can be offered. So in an MR defecography, we place an ultrasonic jelly into the rectum and we ask the patient to expel it. And here you can see that there is a descent of the pelvic floor and there is a rectocele present here, which is retaining contrast, which may be contributing to the patient's symptoms. So coming to my last slide, When you have a patient of chronic constipation, a detailed history is important. A good physical examination, a per rectal examination to check the anal pressure and the ability of the patient to push a palpating finger, give a trial of laxatives, tell them about lifestyle changes, about the correct posture of how to pass stool. But if he has any red flag signs, that is, if there are new symptoms beyond the age of 50, blood in the stool, anemia, family history of cancer, then you must do a colonoscopy and other tests to rule out any medical problem before you investigate further. Once you know that there is no worrying cancer, no obstruction, now you have to find out what type of constipation is the patient suffering for. For that, you will first do an anorectal manometry with the balloon expulsion test. If that is normal, you want to look at a colonic transit study, and in a few select patients, an MRI defecography if you suspect a defecatory disorder. These tests will help you to subclassify your non-responsive constipations to whether they have normal transit, slow transit constipation, or a pelvic floor disorder, so that you can offer them appropriate therapy. Thank you.